So our plan is to go ahead with robotic TAPP repair, transabdominal preperitoneal repair. Those who are doing, there are many delegates who are regularly doing laparoscopic groin hernia repair, TAPP, E-tape, and then there are few surgeons who are there who are trainee surgeons or who are just past MS. So they must have seen but not doing, or they are not very acquainted with the posterior abdominal wall groin hernia anatomy. So I will try to show the each and every anatomical aspect, and along with that, what are the advantages of robotic surgery over laparoscopic surgery in this kind of cases, particularly in the general surgical cases. So after this case, we will post, we have posted one robotic cholecystectomy. And after that, we'll try to finish it off by 12:30. And after that, there will be a dry lab session where you all will be brought here in operation theater, where you will be sitting on the robotic surgical console and will be doing 3-4 exercises on as a dry lab, part of dry lab training module. So you will get accustomed with how robotic surgery works and what are the advantages, and then what is the actual the beauty of sitting in the robotic console, how smoothly you can perform your cases. And then there will be a directive talk session where faculties, national level faculties will be coming, and they will be talking on different aspects of robotic general surgery. So let's come back to the case. So here I'm standing on the left side of the patient. Patient is, this is the OT setup. To broad view करो, आगे to छोड़िए दाओ, पूरा view टा, पूरा OT setup टा देखिए ना, OT setup टा देखिए ना. So this is me standing on the left side of the patient. Patient is after anesthesia. The arms are tucked by the side. The legs are split. So you can see it's a modified lithotomy kind of position where legs are split like this. And this is the head end. This is the foot end. This is the probable site of, now your abdomen focus karo. So this is the site of left inguinal hernia. This is the site of right inguinal hernia. So there is certain things that you need to understand. The port placement will be a little bit different compared to laparoscopic surgery. So if we consider only the left sided hernia, then my target area of dissection will be this. Okay. If we consider right sided space, the target area will be like this. So depending upon the target area, you should be you always should keep your robotic port at least 8 to 10 centimeter away and in line. So it will be in straight line ports. In laparoscopy, we try to maintain the triangulation, but here it is maintaining the port, keeping the port in the straight line is the key. So as this case is a bilateral groin hernia, so we have to decide where is the target. So my target area would be around this. So I will be keeping my port, doing the main dissection in this area. Okay. So that will include part of this area also, part of that area, and right side and left side both. So from here, I have to keep my port scaled at least 10 centimeter away. Okay. So 10 to 15 centimeter you can keep. So depending upon the space you are getting. So I am keeping 12 centimeters. So I'm just keeping one port here, the camera port. And then I will draw a straight line through this port. And between the two ports, there will be at least 6 to 8 centimeter gap. Okay. Between the two ports, there will be at least 6 centimeter gap. So like that, this is my proposed plan of port position. However, I will start with pneumoperitoneum. Once the abdomen gets distended, the abdomen will stretch out, and then I will measure it again and then we'll put. So starting with pneumoperitoneum now. So 1 inch above the umbilicus, and then with Viris needle. Gas on. Rohit ekটু সর. So ওইটা একটু ফোকাস করো, ওইটা ওইদিকে পেশেন্ট কার্ডটা. হ্যাঁ, অন্ধকার দেখাচ্ছে কেন ওখানে? হ্যাঁ, লাইট. So there are you, as you know, there are three parts. Okay, একটা vision cart. This is the vision cart that you are seeing now. So above there, উপরে দেখো, above there is a monitor. Here is a monitor. Right. Here is a monitor, and then below that there are insufflators, and then energy sources. They are all come together, and there is a recording device also. The recording device is separate. You can buy it separate, but the whole thing of light source and then the energy source and the insufflator comes together with this vision system. And there will be two other systems which is patient cart, where robotic arms will be there. Okay, that is mobile patient cart that you can move around the OT operation theater, and you can put your patient cart according to your need. And there will be a surgeon console. So that is the surgeon console that is kept at least 15 feet away from the patient. So I will be sitting over there, and operation will be done here. এখানে বন্ধ হয়ে গেছে। So all robotic ports are 8mm ports. Okay, so this is a 8mm robotic ports. The robotic ports are a little bit different. So you will be showing in detail once you come to the operation theater. So there is gradual marking. So this is the one black mark. This part should be inside the abdominal wall. So this is mainly the fulcrum of the this ports, robotic ports. Okay, so this is the trocar. This is the cannula. These are all 8mm ports. What I'm using is DaVinci X system. Okay, there are different system, SI, XI, X. So this is DaVinci X system. So I'm putting the first port here vertically, and I'll put the gas camera. দেখাচ্ছে না কেন? আচ্ছা, লাইট অফ কর। এখানে লেগে আছে, মুছ, পোর্টের ভেতরটা মুছতে হবে, পোর্টের ভেতরটা গজ পিস দিয়ে মুছ। না না, इसके अंदर ये एक चलो okay, done. Yes, so this is a 30-degree scope, 30-degree robotic scope. It is a bit longer than the laparoscopy port. So I am putting the first, after putting the first port, I am putting the camera inside. So this is the view after going inside. You can see the first of all, after putting the ports, you need to check down whether during the Viris entry whether there is any injury or not. Just overall assess the abdomen. So just do a diagnostic laparoscopy whether everything is fine, and then you can ask the patient to position head down. So you can see there are bilateral direct hernia. The left hernia is bigger than the right. Head down, please. Koro. Bas. Done. So this is 30-degree down. Okay. So I'll put two other ports. So the two other ports will be kept at least 8 centimeter apart. So roughly your 4 fingers. Okay. So I marked it here. The second 8mm port I am keeping. Right. So here you can see if I am putting too much inside, the black band is coming inside. So this should stay inside the abdominal wall. Okay, and then you take out the port. Okay, the next one will be on the other side. Again, in the straight line, I am keeping all the ports in the straight line. Gas stop ko. Right. So again, I have kept these two ports under vision. So I will check whether the camera port, the fulcrum is, where is the fulcrum? The black band should be inside the abdominal wall like that. Okay, done. So now I will ask them to dock. So now the docking part. Okay, dock korbe cholo. So you need to have a trained robotic surgical team inside the operation theater who will help you. So what you can do is your assistant surgeon should be trained. Then the assistant with me, Dr. Rohit is there, who is the second year resident of robotic, I mean the general surgery trainee. And then we have brother Bilipson, who is experienced in robotic surgery. And then Sylvia is there, nursing scrub nurse. Then Dr. Shovik is there in the anesthesia part. Okay, and there are OT technologists who are there is Nasrat and Kunal. So they are all experienced in robotic surgery. How to movement dekho. So they are bringing the thing straight, and you can see the laser light here. The laser light is guiding the OT technologist who is bringing the robotic cart towards the patient. আরেকটু ভেতরে আসবে, armটা পেছনে দিয়ে দাও. So robotic, the patient cart has 4 robotic arms. I will be using only 3 for 3 ports. Bas, done. Now we have to bring the first port. I mean the first robotic arm should be docked like this, and there are, so once we dock, the DaVinci will give a response that DaVinci is docked, and then do not move the patient. OT table cannot be moved once the docking has been done. So after the first docking, then will do the other ports. তুমি লাগিয়ে দাও এটা লাগা বিলিসন, হ্যাঁ লাগাও. হাত স্লিপ করছে. Okay, so all the 3 ports are docked. So if you have an experienced team inside the operation theater, the docking will, there is a confusion, or there is a thing that people think that there is a docking part take much longer time, it will take around half an hour. So actually it is not true. So if you have experienced team, after putting the port, the docking part will take almost 1 to 2 minutes to put all the docks. So once docking are done, and then we are putting the camera ports. Now I will describe now. Okay, so আমার এটা একটু খুলতে হবে, না খুললেও হবে, ছেড়ে দাও, নো প্রবলেম. ওকে, তো আমার দিকে ক্যামেরা করো একটু. Yes. So I will be using a 30-degree camera, and then the right hand working port. Yeah, you can see the scissor is coming, the monopolar scissor is coming inside. Okay, that is arm 3. Arm 2 is holding the camera, arm 3 is the scissor, and arm 1 is, this is an instrument known as fenestrated bipolar grasper. So in right hand I will be having monopolar energy, and the left hand I will be having bipolar current. Okay, for further dissection. Now I will be going to the console, the surgeon's console, and start operating. Okay, and you have the mic inside the auditorium. At any point of time, if you want to ask anything, okay, so just feel free to ask me. I will communicate to you from here. Dekhi Shuraya. हाँ करो जल्दी कैमरा क्लीन करो हॉट वाटर So right now I am sitting on the surgeon's console. If the camera person can show me, I don't know whether he will be able to. ক্যামেরা দাদা তুমি একটু ওইখান থেকে এখন মাথার দিক থেকে সরে গিয়ে এই পাশটা চলে এসো তাহলে দুদিকেই দেখাতে পারবে এমনভাবে ক্যামেরাটা রাখো যাতে পেশেন্টটাও দেখাতে পারো আর আমাকেও দেখাতে পারো ওই হোয়াইট বোর্ডের সামনে চলে এসো না হয় রাইট ডান Okay, so first I will I think you all can see the abdominal view operative view in a big screen. Shoptoshi?
Hello? Yes, sir.
Okay, so I will start describing the anatomical aspect. So this is the median umbilical fold. You can see that obliterated urachus and the bladder is going. This is the medial umbilical fold, this right and left medial umbilical fold, and you can see the, I am coming to the anatomical aspect, particularly for the left side. This is the left side of the patient. So you can see the inferior epigastric fold, inferior epigastric vessels. So that is the lateral umbilical fold here. So lateral umbilical fold corresponds to the lateral, I mean the lateral umbilical ligament. Okay. So this is if you can see the anatomy is clear. So Hasselbeck's triangle, as we all know, the rectus abdominis and then the inferior epigastric vessel and the pubic bone. So this is a Hasselbeck's triangle and the hernia is through the Hasselbeck's triangle. So it's a direct hernia. Okay. So from the upper border of the defect, we should at least keep 4 centimeter above. What we can do is just to, this is a, if you see then here below in the screen, here it is shown that camera is 30° down. Okay. So one camera, there is 30° down. So what I will do is I will make the camera 30° up. Now you can see with one button I have changed the camera position. So this, since this is abdominal wall surgery, so you need to see the upside down view to start with your case. As you keep on doing the further dissection, then the will change my camera position accordingly. Okay. So I will ask the assistant surgeon to show me the where is the anterior superior iliac spine. So he will just palpate from outside and show where is the, this is the anterior superior iliac. You can see he is Dr. Rohit is pressing from there, and that is the where again here, that is the anterior superior iliac spine. So I will give a start giving the incision. Okay. So first I will mark safeguarding the inferior epigastric vessel. Okay. And then here you can see once I am pulling the peritoneum like that, the gas will go inside and start creating space. You can see that already the pneumodissection is going on. So I will just give incision. So this is a monopolar energy I am using, and then is incising. Okay. You can cut and keep on doing incision. See. So the idea is to not just the peritoneum, but you need to include the, you need to go into the pre-transversalis plane. So there will be 2 layers of fascia transversalis. So you need to include the posterior layer of the fascia transversalis and then go accordingly here like this. So each and every blood vessel is so clear that you will be able to see the each and every anatomical aspect. I can go further close here. Okay. And you can see the vessel pulsating, and then you can dissect accordingly. Okay. So I will be going like this. Here the inferior epigastric, you need to pull the peritoneum like downwards, and then so that there should be not be any energy transmission to the vessel. Okay, so the first part of the thing, the incision has been given. You can see the inferior epigastric vessel much clearer now, and the branches toward the rectus abdominis muscle, the perforator branches. So now I'll do the further dissection. Following the, so this is the peritoneum, this is the fascia transversalis layer, the loose areolar tissue is actually the fascia transversalis. So I am staying in between the two layers of fascia transversalis. Sometimes in thin built patient, the peritoneum is also thin. There is lack of preperitoneal fat. You have to be cautious. The peritoneal, the undue rent should not be created. Anyway, if the rents are created, we'll repair it at the end of the dissection part, after patching the mesh and all before closure. So further dissection is carried out like this. So using monopolar energy, the tip of the scissor, I am just applying monopolar energy and doing the further dissection going downwards like this. So here what is the advantage, you yourself is controlling the camera and all other two instruments. So you are not dependent on the camera person. That is another advantage of doing robotic surgery. So here according to the where you want to see, you can push your camera to that side and then see and go on doing the dissection. So inferior epigastric vessel should be always lying up on the abdominal wall, and then the loose areolar tissue you are seeing very nicely, and then doing the dissection, safeguarding the inferior epigastric vessel first. So that is the first thing you need to be very cautiously doing. So now there is a little bit of bleeding. So what you can do, you can just use your bipolar instrument and just cauterize here like this. Okay. There are small perforator branches from the inferior epigastric vessel that will be coming towards the peritoneum and also the rectus abdominis muscle. So you need to be identifying, you can easily identify using robotic console those branches, and you can cauterize. So initial part of dissection I am doing with camera up. So once I am going towards the pelvis, toward downwards, so I can change my camera direction to like that. So now you can see I am just dissected enough from this vision. Now I can change my camera dissection, but little bit of lateral dissection I will be doing, and then I will be going towards that spleen. Okay. Now I will change my camera direction here, and then adjust my camera position, and then close, go close to this. Now you can see the change in vision, right? Okay. So here from this plane we need to go laterally into the 3 transversalis plane. So I am just dividing the fascia transversalis laterally, and you can see the lateral plane of Bogros will open up. See, you can see. So lateral dissection should be done first to get adequate after getting adequate lateral dissection, then the medial dissection, and then finally you will target the sac. So bit by bit, see, you can see nicely I am just lifting the tissue with my one leap of the scissor and then doing the further dissection. So I will go inside, get a better vision. Sorry. Here, see how close I can go to the. Here some bleeding is there, I think from the peritoneal aspect. I will just cauterize here like that, and then I will go here, just lift off, cauterize, and then divide. Okay, so the peritoneum is very thin with very less amount of preperitoneal fat, so you have to be cautious. So there should not be too much of peritoneal rents during the process of dissection. Okay, now you can see. So I'm just trying to open up the space of Bogros. You can press your left hand instrument like this and then do the further dissection. Okay, laterally there will be Dulux fat. So Dulux fat is one structure which is actually protecting the lateral abdominal wall nerves, the branch of genital branch, genitofemoral nerve, and all the branches are protected by those fatty layer. So that fat should remain on the lateral abdominal wall like that. So there will be two layers of fat. One is preperitoneal fat and the other will be Dulux fat. So you can see that how I am doing the dissection with the back of the scissor. I am just trying to create plane, and with my left hand instrument I am just giving good amount of traction. So it's all about giving traction and counter traction, and the plane will open up. Okay, like this. Now you can go do the further dissection here. Okay, gradually towards the defect area I am going. So lateral dissection, if you could do the lateral dissection beforehand, so there will be enough space for you to do the further dissection, and initial part of the job is done, and you can move on to the concentrate onto the other side. So you can see this is the Dulux fat I am talking about. I am just keeping it on the lateral abdominal wall like this, and then bringing down the peritoneum and the preperitoneal fat laterally here. Okay, I'll do this dissection a little bit later. So first, so you can see the lateral dissection is more or less 70-80% done. We'll do rest of the 20% later. So I'll try to concentrate on the medial aspect now. So there is a direct hernia. While doing the medial dissection, you will be encountering the hernial sac. So what you can do is just keep this fat should be lying over the abdominal wall, and you just release this loose areolar tissue, the fascia transversalis, and then this layer also, the fascia transversalis, and go gradually towards the Okay, so there are small blood vessels that you will be able to see. So you can just cauterize with monopolar and divide with the scissor. Okay, and going like this. Okay, you can see the inferior epigastric vessels and the branches. Now the hernial sac, this is the hernial sac is going like this. This is the rectus abdominis muscle, inferior epigastric vessel, as we are telling about the this thing, Hasselbeck's triangle. So, and now I am coming on to the further medial aspect toward the space of Regius that we have to create. Okay, so like this I am just pushing it up and down, so you can get into the cave of Regius basically. So you can appreciate. So this is with left hand I am doing dissection, and now you can see the glimpse of the lighthouse sign, the pubic tubercle, the whitish. You can see the bone now. Is it visible? Okay, inside. So I have seen the first anatomical landmark. So what we will do is, for further dissection medially, I will try to reduce the hernial sac now itself. So it will become much more easier to do the medial dissection. So now you can see I am just pulling the hernial sac. I will ask the assistant surgeon to press over the left groin area. So he will keep on pressing from the left groin area, but that's it, done. And you can see this structure, which is while I am pulling this inside, there is a structure which is coming inside. This is known as pseudo sac. So this should go up. This is usually seen in the uh, direct hernia, but in case of large indirect hernia also you can see. So this, once you pull now, there is very loose connection of this, and then you can, with the back of your scissor, you can just push it off. Like this. There will be small vessel, you can easily cauterize and then push again, and then further dissection, press kore rakh. ठीक है, done. Okay, you can see just nicely I am holding it, and the with the back hand of the back side of the needle, I mean the scissor, I am just pressing it and doing the further dissection. Okay, and again, as you keep on dissecting, just keep advancing your left hand instrument to hold the preperitoneal fat. Sometimes in large direct hernias, bladder, the corners of the bladder can get into the can become the hernial content, so you have to be cautious. Okay, again you hold, you advance your instrument and do the further dissection like this. Again hold, pull, go close with your camera. Each and every fiber is visible. So what you are seeing is actually the 2D view, but what I am seeing is the 3D view. So it's almost like a feeling will be almost like sitting inside the abdomen and operating. एकटू ढीला छेड़ दे. Now you can see I have almost reduced the hernial sac with the preperitoneal fat. Just gradually you can see the, now leave it. Okay, so I will do a little bit of dissection here to try to release this structure. Okay, and then again I will be pulling this structure and doing further dissection. So once you keep on separating this preperitoneal fat from the pseudosac, the pseudosac will automatically go away from the dissection area. And once you reduce the hernial sac, so you will be able to see the, then again the pubic bone is visible now. Okay, so again a little bit of dissection left here, so I will complete the dissection here and then do the other part dissection. So if you are following the correct plane, there will be hardly any bleeding. So that is the, and if you can see better, you can do the good dissection. So I am sitting and operating, having a great view of the anatomical aspects here, and I am very sure about what I am dissecting and doing further dissection. Okay, so little bit of oozing can be there. You can just with your bipolar can cauterize. Now you can see the hernial defect. Okay, and the inferior epigastric vessels, and I will come to this side again. Yes, so these are the arch fibers coming like this, so sling fibers, so that you have to divide, okay, like this, and then the idea is to achieve critical view of myopectineal orifice. Okay, so myopectineal orifice, I think you all know what is myopectineal orifice. I need not to repeat this, but I will try to show you how it has been created. So you can see the Dulux fat. I am just swiping it off away from the sac. Since it's a direct hernia, there will be only cord structures, and I need to rule out whether there is any cord lipoma. So cord lipoma will be like going in this plane. Okay, there can be a cord lipoma which I will dissect further, but first I need to clear off this area better. Here like this, push away the fat, and you will be able to see the cord structures. Okay, now you can see this is the, sorry, yes, here. Now you can see this is the vas difference, and the gonadal vessels are clearly seen, and this is the sac border, the peritoneal reflection here. So I need to dissect above this. Okay, so we need to bring down the peritoneum further to achieve the critical view of safety. So I need to be cautiously doing this part of the dissection, so they should not be during the part of the dissection, there should not be any undue rent in the peritoneum. Okay, here just dissect and then you divide. There will be small cremasteric blood vessels will be there. You can divide it if it is required, but not the testicular artery vein. Here is the testicular artery vein. This is the peritoneal reflection. I will go close. This is the peritoneal reflection. You can see this is the testicular artery vein. This is the vas deferens lying medially. So I can gradually divide this fatty layer, and it will release the cord structures. Okay, and separate the fatty layer. একটু ফোনটাকে কথা বলছে, একটু অফ করতে হবে। Okay, gradually bit by bit there can be chance of bleeding, so you need to be cautiously cauterize and then do the further dissection. Okay, So gradually the peritoneum will come down. Here you can see I'm pulling it with my left hand instrument, and this is the cord structure, this is the peritoneal fold you can see, and I can divide this. So this will gradually, this is known as parietalization of the peritoneum. So parietalization of the cord structure rather. So cord structure at the structure should be lying on the parietes, not in the. So this, once I'm dividing this structure, so the cord structure should go, and gradually as we keep on dissecting, the cord structure will separate. So vas deferens will go medially, and the gonadal vessel will go laterally. So in that is how we achieve the critical view of MPO. You can see, okay, and then the little bit of dissection here. Here you can see the peritoneum. I will just push off the peritoneum down, and then using the back of the this thing, the scissor, I'm just dissecting it off. Again pulling the peritoneum, seeing what are the structures that are holding the cord structures. I'll just gradually, I'll just using energy, so cautious application of the energy source. I will not directly hold the cord structures, okay, particularly the vas, I will not be holding it directly. So that is to prevent any injury to the cord structures. So I am just pulling the other way around. So other structures are pulled, and then under vision I am just separating. So again the dulux fat you can see, okay. So behind the dulux fat is psoas muscle and the overlying nerves, the genital branch of genital femoral nerve, the lateral femoral cutaneous nerve, whatever nerves will come on the other side. So if there is a good amount of dulux fat, you should not disturb it. So if you don't disturb it, then there will be very less postoperative pain, and the chances of chronic pain is very less, okay. So again here I'm lifting it off. You can see the peritoneum laterally here. I'll just push it off down like this and divide this structure, okay, here like this, okay, and then divide it. So I'm gradually coming towards the now I will do a little bit of medial dissection. Here you can see the vas deferens and the artery to the vas, so this should not be injured, okay. And as you keep on doing the further medial dissection, you will be seeing the external iliac vein and the obturator nerve. If you do the further dissection medially, I'll try to show you. So this is the bluish structure you can see. This is the external iliac vein. So you have to be very cautious, okay. There should not be any undue application of energy over that area, okay, like this. Again hold it more proximally, see what are the structures, try to do the blunt dissection, and if there is any vessel you just cauterize it like this. Little bit of application of energy here down, because behind this there will be external iliac artery, so you won't be interested in application energy over there. Okay, so okay, so you can see I'm just I'll just go close and see what are the structures. The loose areolar tissue planes, stay away from the vein. Be very gentle in this part of the dissection. This is the actually the final part of the dissection, so you need to be cautious. here I'm just pulling and will be dividing this. Okay, this is the Cooper's ligament, you can clearly see, and this is the obturator foramen. Now I am just going here. This vessel is the obturator vessel. Okay, there will be obturator nerve over there. Okay, they are covered by fat. I'm just not disturbing them. So since this is a direct hernia, idea is to go, so for any hernia dissection you have to go at least 2 centimeter from the Cooper's ligament. You need to go down dissection, doing the 2 centimeter dissection at least down, so that you can go give the good overlap. Mesh overlap should be nice. Okay, so this is the bladder, you can see this is the bladder wall, this one is the bladder wall. Okay, and this is the undersurface of the pubic bone. Okay, this is the hernial defect, and this is the anatomical aspect. I will show you again. I'll just do a little bit of dissection here. So okay, laterally, nice space is created, you can see. Okay, with good vision and understanding you can dissect it further, and then I'll be doing the further dissection on the medial aspect. So this is a bilateral case anyway, I have to dissect from the other side also, but if I can do a little bit dissection from this side, the other side dissection becomes will take much less time. Okay, so this is the median raphe. What I say is median raphe, there is a midline. Okay, so I'm doing the dissection gradually, dissecting the fat. Will gradually, for a single sided hernia you need to expose the midline, you have to cross the midline at least 2 centimeter onto the opposite side, so that should be done if you are doing. Okay, so I'm just pushing the fat above. There is a midline fat that we encounter during the hernial dissection. So bladder is down, so you need not to worry about the bladder, because bladder is below my left hand instrument. So this fat should go up, and there are small perforator vessels that you can cauterize. So this is the symphysis pubis now getting exposed. This is the midline. Okay, this is the symphysis pubis. This is the undersurface of the left rectus, and if you want to the opposite side, you can expose the right rectus also. So this is the right rectus beyond the midline. So little bit of division here would help. Little bit of bleeding here. I'll just try to find out the source and then control it. There are small perforator vessels which may bleed, so you need to be Okay, done. So I go on to the opposite side now. Okay, I can do the suction. We'll do the suction later. Little bit of bleeding, oozing if it is remaining. The bleeding is controlled. So sometimes there are vessels which can bleed. This is actually the bleeding vessel, so that I have cauterized with bipolar instrument, and then do the right sided dissection. So left sided I have achieved this critical view of safety. You can push the, this is a sigmoid colon, you can see. Okay, so this is a sigmoid colon which is pushing this area. So I have actually dissected enough. So again, while applying the energy sources over here, you have to be cautious that gut is just below the peritoneum. So if there is peritoneal rent or something, the direct energy application will be on the colon on the left side. So that should be cautiously done. So now you can see the nerves overlying over the psoas muscle here. There is a layer, loose areolar tissue layer, the fatty layer is there, that should not disturb. So these are the two nerves you can see, and there will be many other nerves which should not be disturbed. So I will not be applying any energy sources here. I will just release the fatty tissue. Okay. Okay, fine. So I will do the right sided dissection again. So right side anterior iliac spine, I will just need to check. I will ask my assistant surgeon to show me the right anterior superior iliac spine, where it is. Anterior superior iliac spine, there, fine. So you can see the hernial defect is lesser than the other side. So I will just here we'll start from, so this is again 30-degree, down is there, I will make it up. Okay, like that I have done in the previous case. You can see now the anterior abdominal anatomy, the inferior epigastric vessels and all, everything is clearly visible. Okay, this is the medial umbilical fold, right medial umbilical fold. This is the inferior epigastric vessel, the Hasselbeck's triangle and the direct hernia. Okay, right. So starting, we'll be starting giving the incision, at least from this point I will start giving the incision. So as we have done the dissection on the other side, there is pneumo that has gone onto the right preperitoneal space also, and did the initial dissection. Okay, so I'll just keep on incising and the plane will automatically open up for me. So just beyond the inferior epigastric vessel. Okay, like that. In this line I'll give the incision. So here, okay, you can see already the dissection has been done on by pneumo dissection has been done on the other side. Okay, just pull the peritoneum and then there will go further inside and do the dissection. So you can see the two layers very clearly. This is the peritoneum, this is the fascia transversalis. You can see there is a clear demarcation between the two plane. So you need not to go into that plane, you go into this plane. So there the flap becomes thicker and there will be very less chance of damaging the peritoneum during the process of dissection. Now you can see I am pulling the both layers together. The fascia transversalis will come down, the posterior layer of fascia transversalis will come along with the flap, and this kind of exclusive vision you will only get in the robotic surgery. In laparoscopic surgery, until and unless very high definition system is there, you can see the two layers, the peritoneum and the pretransversalis, the fascia transversalis, posterior layer fascia transversalis. So I am just incising both here. You can see the second layer also incised. Okay, and then the loose areolar tissue with the fascia transversalis plane, I can go into venture into the pretransversalis plane down. Okay.
Sumanta, good morning.
Morning, Samrat sir. How are you?
I'm fine, man. I'm fine. You are doing wonderful dissection and going surgery. Very good.
Okay, thank you so much, sir. I hope your journey was smooth.
I absolutely fine. Yesterday night we landed and we are there from the start.
Great, great.
Sumanta, if any laparoscopic surgeon
Hmm.
is doing a robotic tap, planning
Okay.
for robotic tap,
Mm-hmm.
what exactly difference you will tell from
Hmm.
the start? You have shown the docking,
Hmm.
how distance you need to go.
Hmm.
For the incision, is it your laparoscopic incision where you start and robotic is the same, or a bit of higher you are taking up?
See, the incision is more or less same.
Okay.
So I usually generally prefer to give a little bit higher incision both in laparoscopy and robotic. So
Okay.
the line of incision should be at least 4 centimeter above the this thing, the upper border of the hernial defect, so that the gradually you can proceed. Once you proceed further, so you can just keep on dissecting in this plane. So the perforator branch, I'll just cauterize it. Yes. So as I was saying, so if we can start from a little bit above, the peritoneum and the first flap becomes a little bit thicker, which is easy to handle.
Oh, yeah,
Okay. So again the perforator bleeding is there. Okay. So in that way, it little bit for me it's a little bit easier, because uh, I prefer to give this kind of incision. So there is no difference in the incision, as you said. There is no difference in the incision, but the dissection becomes much more easier because of the vision I am getting here in the console. The 3D vision. If there is any, even there is all the blood vessels are clearly seen, and even if there is any bleeding, so I have my bipolar on the my left hand instrument. So I can then and there cauterize. No need to change the instrument. You can see this vessel, and then I can use the bipolar and then cauterize then and there, and then go do the further dissection. So no need to change the instruments and all, and you can create a bloodless plane of dissection.
the vision is appreciable. Vision is really very nice as compared to laparoscopy. I think in console, you surgeon console again more better vision we can
Yes, yes,
appreciate.
yes, sir. Because it's 3D vision, so it's like almost like a real time. I mean, it's as I was saying, like it's sitting inside the abdomen and operating like thing,
Yeah,
feeling.
yeah, that's true. It's appreciable. Till you go to the pubic, you will be making a 30-degree up and then down when you go into the deep
So
pelvis.
that depends, sir. Here in the abdomen is like this. So I am doing the on the abdominal wall. I am doing dissection. As we keep on going, we will dive into the deeper plane. So once I feel that I am not very comfortable with the 30-degree up vision, I will then and there I can make the 30-degree down vision and do the further dissection. Till now I am okay. I am comfortable. So my idea is to do the lateral dissection as much as possible with this vision, and then the other way round when I am doing the I'll be doing the pelvic dissection. Only thing is lacking is the feedback, the haptic feedback. So that thing is lacking. I think the DaVinci 5, the newer generation DaVinci is coming with that. They are working on that, and they will be bringing the DaVinci 5 is they are claiming that you will get a feedback on the instrument that we used to get in the laparoscopy. So that thing will be also be available with newer generation DaVinci robot. So here whatever I am doing with the experience of laparoscopic surgery, so I am just how much pressure you have to create. I mean, while holding the peritoneum, you cannot put too much pressure, so it will tear of the peritoneum, and you won't be able to appreciate it is getting torn.
The arms are very powerful. Way
Yes,
you
yes,
are handling gently,
yes.
it's not that easy because arms are holding grip is very powerful.
Yes, yes. So how much pressure you need to apply while holding the structure, so that thing is to be will come with training, will be as you keep on sitting and operating. So during the training phase they will make you understand how much pressure you need to apply, and then what are the excessive pressure will damage the tissue, because these are all soft tissue structure, we need to handle them very gently. So that thing will come with training part.
More and more time exposure on the robotic.
Yes, 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 of course. So while there is a particular training process that you need to go through, the tier 100 course is the first of that. So there you have to sit at least spend enough time, at least 50 to 60 hours on simulation. So there will be simulator, that there will be certain exercises that you need to do, and while doing they will show you if there is excessive application of pressure, they will show you there is excessive application of pressure, then you need to hold the grip lightly, and then the energy application also, how much energy application should be there so that the tissue should not get charred. And then the ergonomics, the instrument, both the instruments should not be hitting each other. Okay, so those are the training modules that you need to go through to get accustomed with the robotic instrument. So this, there is no haptic feedback, so even if you hit the two instrument you will feel a little bit obstructed, but there will be, as in laparoscopy you get in the feedback in hand, that will not be there. So there should not be any heating. So for that only the outside hand movement is very important, that I am doing sitting in the console, the outside hand movement is very important. So the separate training modules are there in DaVinci system. So that is fantastic training program they are having. So now I will change my camera position here, like that 30-degree down I have kept. Okay.
The best part about that stimulation module is every time it will give us how much excess energy applied,
Yes.
how much excess you have handled the thing, where you have crossed, or instrument ergonomic has been disturbed, everything.
And you can see the articulation, the advantage of articulating instruments. So what I'm doing, I mean, is holding and just bringing it down, not pulling it towards me. Just bringing it down will expose the plane, and then you can proceed further like that. This, and then bringing it down. Okay, but again the how much pressure, how much traction should be given, that will come as we keep on doing robotic surgeries and sitting, and then you will get a fair enough idea that how much pressure should be given. Okay, so I'll finish off the lateral dissection first and then go on to the medial part here. So again the lateral side also preperitoneal fat is less here. Usually in well-built patient you will get a fair enough. So you can see this is the fat, this is the dulux fat, and this is the peritoneum which is very thin. So I need to go into that plane. So this plane I have to go. So you need to push your left hand instrument, so give a good amount of traction like this, and then divide the fascia transversalis like this, and then keep the fat on the abdominal wall. These are dulux fat which will be protecting the nerves. So there will be small blood vessels. Again you can cauterize with monopolar or bipolar. Yes. So again push it off. You can see how thin the peritoneum is laterally. So I need to go on to that plane to expose the space of Bogros. As you all know, the lateral space of Bogros. Like this, you have to pushing, little over traction, counter traction is very important. Push, push, so that the fat should remain on the lateral abdominal wall, and you can go into the deeper plane here. Hold the peritoneum very gently and then push like this, push like this. Okay, so you will expose the space of Bogros. Okay.